So I'll just kind of fly through this quick, just sort of talking about drugs. It can stop me at any point. This is taken from a lecture I did for the residents, so kind of can be very informal here. So treatment of MS, the most important is actually lifestyle. So staying healthy, diet, exercise is critical for any chronic disease, but especially something like multiple sclerosis in conjunction with effective medications. But kind of the main focus talking about are disease-modifying therapies. These are the drugs that treat multiple sclerosis, the disease itself. So the goal of it to reduce or prevent relapses is the primary indication. So big events that can leave disability, we try to reduce those and new lesions as well. And hopefully prevent disability from new relapses. What we don't have great medicines for is that kind of progressive phase of disease, but early treatment with effective medicines can delay or prevent it. So that's kind of the best we got right now. So it doesn't actually treat the symptoms that you have already, though. That's not really the role of the medicines. So kind of you can do lots of different things with deciding on what medication to start patients on, and it's very patient-centered decision. It depends on a whole lot of factors, and there's no consensus about where you should start between really effective therapies or lower effective, safer therapies. That's kind of the basic way to think about it. So the two main strategies of treatment is going to be high efficacy first. So these are newer, more potent drugs. Many of them are infusions against sort of the step up, which is the classic style that we use in most of medicine. So go low, start slow is sort of the mantra in most that we do, but it may not work in a disease like this. I've kind of used almost all of the drugs at this point in the right situation, but I tend to favor the higher efficacy first for most patients. And again, it's a patient-centered decision. So how come if there's newer drugs and they're pretty safe and they work really well, how come we don't start everybody on those? Some of it is that's new, and neurologists weren't typically trained to be immunologists. And now because of all the advancements in these diseases and treatment, kind of have to be now. So there's some getting used to that aspect of the job. And then once you start an aggressive therapy, when do you stop it? And that's very unclear. What if you didn't diagnose them right and you're treating the wrong thing? You maybe could really harm somebody. And that's just kind of the idea. There's also this part here, which is this is sort of a timeline of all of the disease-modifying therapies over time. So we didn't have anything specific for multiple sclerosis until 1993, which in medical advances time, that's actually not long ago. We had 3 main drugs. They're all injections you do multiple times a week. And that for the first 10 years, that's basically all that was available. And they work okay. Better than nothing, but they're not that good. And then we developed this really potent, great therapy called natalizumab. I'm sure you've heard of Tysabri. But soon after it came out, it was pulled off the market for developing PML, which is progressive multifocal leukoencephalopathy, which is this very terrifying thing. And then it got put back on the market with new warning labels and everything, and it's still on the market. We still use it today, although in some ways it's been supplanted by some newer stuff. So we went from medicines that didn't work that well, that were safe, hard to harm people, to medicine that worked really well, that we could easily cause a lot of harm. So that I think that would be tough for practicing neurologists during this time period to trust the newer medicines. And then in the 2010s, that's where all the pills came out. And that was pretty popular for a while. And then in 2017, we got Ocrevus, ocrelizumab, and then other B-cell therapies after that. So that's kind of, and there's another one that came on the market and taken off for safety, and it's still off the market. And then we got some newer stuff too. So we really haven't had highly effective, what we consider now to be highly safe therapy until 2017. So that's why there's so much variance with each neurologist's style of treatment, and there's lots of reasons for that. This is kind of the way we think about our medicines. So this is broken into 3 categories between low efficacy, medium, and high. So the lows are 30% reduction in annual relapse rate. So on average, patient with relapsing or remitting multiple sclerosis will have a relapse about 3 times a year. So that cuts it in a third, which is okay, but not that great. And then we cut in half, and then we could cut it almost gone. So that's kind of the variance there. And the colors are the way that you give it. So the yellows are injections. These are self-injection medicines. The ones over here on the low side, interferons and glutamine acetate, are a couple times a week, typically. And then the one up here, the newer one, ofatumumab Kesimpta, is once a month. And then we have a bunch of pills in the green. Most of them are in the medium range. And then infusion-wise, we have these drugs. Ocrelizumab is the main one, and then we have some newer versions of it. And then there's natalizumab Tysabri again. We really don't use this one at all. I just mostly put it on there for the residents to know what it is. And kind of there's pluses and minuses with all of these. So the benefit of these yellow ones here on the low end is that they're extremely safe. You can even continue it during pregnancy. So that's a big use, because most of our patients with multiple sclerosis, especially new diagnosis, are in childbearing age. And then the mediums are really tough. Essentially, none of the pills are safe for pregnancy. So that makes it really tough to use them in that situation. And they're not safe for breastfeeding either. It's also challenging. And then some of the newer ones we can use at a certain point with pregnancy, although we try to avoid it if we can. That's probably the main aspect that makes us want to switch, or if patients are advanced in their disease so much that it becomes actually unsafe to give them a really strong immune therapy. You can actually cause more harm that way. We could go into all the drugs, but I think we can probably just hold there, because it's just be probably enough information. And just kind of with all of the drugs, they're all approved for relapsing remitting multiple sclerosis. They're all approved for clinically isolated syndrome, which is kind of one attack and then looks like you might develop MS later. And they're all approved for active secondary progressive MS, which is kind of vague anyway. But only one is approved for primary progressive MS. And what you use for secondary progressive MS is extremely unclear. But that's just kind of the breakdown of them. Yeah. Okay. So any questions on that stuff? All right. So I'll probably just stop there.
I have a quick question, Eric.
Sure.
You had mentioned in one of your earlier slides, one of the questions that neurologists might have in deciding on a treatment, and that was when to stop the aggressive therapy. Is it sort of common for people to start these like newer aggressive drugs and then later go off of them? It has typically been my understanding that a lot of neurologists have the approach of like, if the drug is working, keep using it. Can you just speak to that a little bit more?
That is a great question that we don't know. So I think age plays a very big role in that case. And our medications, the evidence we have for any of the multiple sclerosis treatment after the age of 55 is pretty low. And then after the age of 65 is almost nothing. I do have plenty of patients that we continue on these medicines because we think it's helping. But usually the disease is less inflammatory by that point anyway. So that may be a reason to start stepping down. Increased infections definitely will make you want to second guess what's going on. Then during the COVID pandemic, this was a huge thing. A lot of our patients were on B cell therapy like ocrelizumab, and patients had a higher risk of severe COVID when they're on that drug, especially those with advanced disease. And then the vaccines don't work very well when you're taking B cell therapy like ocrelizumab. So we would have patients stop the medicine for a period of time, try to get a good vaccine, and then maybe restart. There was a lot of different strategies, and no one was really sure what to do. And that's why it goes back to patient-centered. Now, if somebody's on a pill therapy and they're doing great and they're not having any side effects with it, and their blood work looks fine, they're not having infections, totally reasonable to continue. But you just want to keep assessing, especially in the older age group of patients. Certainly once we're getting to 65 or past, really reassess every year. Do we even need to still be on this anymore?
Yeah, thank you so much for that, Dr. Seacrist. Are you also seeing that trend with the COVID vaccines currently in 2024 of people sort of making that decision to relook at their therapy to take the vaccine and then go back on it?
Certainly not where we practice. I'm not sure if it would be different in other places. We're a bit of our political stance goes with vaccine stance. Kind of leave it there. But so it's kind of, and I think the worry with COVID isn't what it once was. Certainly during the Delta wave, I mean, that was devastating. And we had a fair number of our patients have severe disease from COVID, and we lost some of our patients. So it's now to have a severe COVID infection, even on these drugs, is pretty unlikely. So we feel differently about it. And because those medicines stay in your system so long, particularly the B cell therapies like ocrelizumab, even if we stopped it for 9 months or we stopped it for a year, you still may not get a very good vaccine response. So it made it really practically very difficult to stop the drug long enough to hopefully get a good immune response from the vaccine during a peak time, because it was already too late, essentially.
Dr. Seacrist, with some of the more aggressive treatments, what are some of the, I guess, critical side effects that providers or patients should be looking out for as a way to determine if they are on the best line of treatment?
Sure. And I think the main idea, it just comes down to, sorry, I'm jump ahead a little bit to get to some of these guys. It depends on the disability level. If you're higher disability, wheelchair bound, substantial bladder dysfunction, then you're going to be much higher risk of getting bladder infections, bed score kind of things. So pneumonia, so that's where you're a higher risk category of getting infected. And then if we're really affecting your immune system strongly, that's just going to make that worse. So that's probably the most important consideration when we're thinking about the really potent medicines. But with some of these in particular, natalizumab is kind of the most notorious when we think about side effects and safety. So this is the one that has probably 98% of all the PML cases with MS therapy. Now, the pills can do it too. All the other infusions can do it. But it is mostly with just this drug. But with the careful monitoring that we do, if you stay JC virus negative during treatment, your risk is extremely low. I think that's sort of PML is basically the boogeyman of MS treatments. It keeps MS providers up at night because we do worry about our patients getting this because it is oftentimes a far worse thing than MS. And you never want to cause a severe issue because of treatment. So that's always something we are concerned about. The natalizumab is the main thing is worrying about PML, which in the right setting is still a very good treatment as long as you monitor it close. The B cell drugs like ocrelizumab and ofatumumab and the new one, I can't say that. The other new one, it's really infusion reactions happen a lot, but they're not severe. Like it's rare that we have patients not want to take it. It's more kind of accrual of infections. So all of these good drugs will set you up for shingles, and you can get pretty severe shingles infections, higher risk of urinary tract infections and stuff like that. And then alemtuzumab, which we don't use that often, can have all kinds of fairly severe side effects. And then one of the pills, it's really infections again is the big worry. So that's the main thing, although in some of the trials, the infection rates of ocrelizumab were the same as having someone on interferon, which is a very low efficacy drug that's been around a long time. So it's a little bit mixed bag, but our main thing we worry about is infections.
Thank you. And is the goal for anyone who receives an MS diagnosis to be on a DMT? Are there certain indicators that you look for when it's time to start DMTs, or are they typically started immediately for all diagnoses?
So the more evidence we get, the earlier you treat, the more you're going to impact the disease. Because when you treat MS with these medicines, you're not just treating this short period of time. Like take our typical example patient. They had an eye attack a year ago, couldn't make the diagnosis at that point, but were worried about MS. And then they have another attack a year later, have a spinal cord hit, and then they have some trouble walking afterward. So that patient already has some disability developed before they're even diagnosed. And then we want to keep them as good as we possibly can. Because in that before diagnosis period, they've probably already accrued even more damage with lesions to their brain or spinal cord that haven't caused clear symptoms yet. But one of the newer theories with the disease is these kind of old areas of damage that don't seem to be doing anything now, 20 years down the road, as you kind of lose your ability to compensate, then those become more active. And that's where that secondary progressive kicks in. So treating, preventing new lesions, preventing new attacks helps in the short term, preventing a disabling attack, prevents new lesions, and that helps you in the middle. Because once you start developing disability, it can kind of keep spiraling. And then long term, hopefully it can prevent that progressive phase of the disease too that we see a lot and start to affect cognition and other things as well. So it's really the earlier the better. And the trade-off with that is if you kind of misdiagnose, you get more worried about that, then you're committing somebody to really powerful immune drugs that maybe they don't need. So it's a delicate line to walk. But if it's a clear-cut case, should be on treatment, with rare exceptions of really advanced age. So I diagnosed a couple of patients in their 70s with progressive multiple sclerosis, and no one knew they had it until that point. Based on where they were in their life and our evidence for the medicines at that age, we decided to not do any immune therapies. But younger patients, relapsing or remitting disease, almost everybody should be on therapy.
Thank you.
You mentioned that when you were talking about the goals of DMT, Dr. Seacrist, that it doesn't really treat current symptoms. And this is something that we've heard from people living with MS as well, is that they kind of have a different language when it comes to their doctor from what the medicine is supposed to be doing as far as like curing, treating, reversing, etc. Can you maybe talk about that a little bit more about some of that
Sure.
disconnect and what could be done, especially through like primary care to help make sure that everyone is on the same page?
Yeah, it's a really tough part, and we run into this a lot, and that's why we kind of reiterate this over and over again as much as we can. Is the goal of the therapies is to prevent new episodes, prevent worsening disability, new attacks, new lesions, but not the symptoms we have day to day. It's not really going to affect that. And we don't have anything that actually reverses what's already there, with the exception of a brand new attack. There's a window that we could probably use steroids or some other treatment to help you recover faster. So really, when we think about treatment, especially in the new diagnosis period, we're talking about what can we do right now, the acute treatment for the symptoms you have. Can we help you recover from them quickly? And then we think about our chronic maintenance, which is let's treat the disease itself. It means we'll kind of try to keep you where you are. And then the most difficult and one of the most important is the symptom management, because that's a whole different arm of MS care and is really challenging because you have to take into account all of these different body systems working together and medications that can make one worse. It gets really challenging if we want to treat somebody's bladder spasms, their overactive bladder from a spinal cord injury. We can give them a medicine, but that same medicine could make their cognition worse. So it's just it gets into a really difficult trade-off period when we're thinking about symptom management. And we do have to work with the primary care doctors because they're going to be managing some of that as well. And they could start a medicine treating something else that makes other things worse. So there's a lot of overlap, and it would be very easy for patients to get mixed messaging for sure.
Are there any other questions or comments before we move forward? All right. Well, thank you so much, Dr. Seacrist, for your presentation and talking about all those medications. We are going to go ahead and kind of transition to the patient perspective. Let me get some of these screens off. I've got 3 screens going. That's a lot. So, so what we can do is whenever you're ready, Michelle, you can just kind of talk about your experience with MS, anything you really want to talk about and tell the group, and then that way we can ask questions and you just kind of take control of it. So whenever you're ready.
Hello. Can you see me?
I
Can you
can't see you. No.
Okay. Hold on.
There
Hi.
we go.
Hello, there I am. Well, I have 100 questions now that I've just heard from the doctor. My name is Michelle Manns. I was diagnosed in 1999 with MS. And at that time, there were only 3 drugs. They were called the ABC drug, Avonex, Betaseron, and Copaxone. And now there's a whole rainbow of different drugs. Initially, I'd gone in because I had numbing on one complete side of my whole body. They thought that maybe they sent me to a blood doctor, a hematologist, and they tested my blood and thought I had a protein C deficiency. Well, come to find out, I don't have a protein C deficiency. My blood work got mixed up at the hospital by accident, and I was on Plavix for a spell, and my doctor told me to start taking it. So to make a long story short, this disease is, I really can't put it into words because it affects everyone different. Every single one of us are completely different. I had a hard time when I stopped working because my neurologist at that time thought it would be best that I didn't work because of the stress. And it affects you mentally, physically, and emotionally. Right now, I have so many questions after listening to the doctor because I'm wondering, do I need to be tested for the JC virus, for PML? Because now I'm on Ocrevus. Every 6 months I get an infusion. And it's hard for me to have energy. Like I got a trillion things to say, so I'm trying to sum it up really simple because I know we're on a time. But I'm just thankful to be a part of this today. And that's all I can say. I'm just thankful to even be sitting here upright, being able to communicate with you all. I'm sorry, guys,
Why are you apologizing? It's totally
because
fine.
I'm blah, 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 blah. I
That's
talk
what
to
you're
me
here
myself.
for.
Yeah, and plus I had a freshly brewed cup of Starbucks coffee out of my kitchen. So I have energy for the rest of the day.
Well, that's good though. It's better than me. I had a cup of coffee and it didn't even help. So
I'm sorry. Maybe I'll rub off on you.
yeah,
Get
yeah.
some mantra. Do you have any questions for me?
Michelle, thank you for being here. I know you and
Hi.
I talked. It's always great talking with you and hearing from your experience and your insight. So thank you for sharing
Thank you.
today.
Thank you.
My question would be, in your journey with taking the medications and seeing what's best for you, what doesn't work for you, what are some of the key side effects or key indicators you look for to really feel like something is effective, it's working, it's worth the side effects that come with it? Are there things that you are really important to you that you like to have conversations with your physicians about?
Yes. Well, the first thing is I was on beta seron to begin with for years. And my neurologist told me that my body would become immune to it. I took his word. At that time, you don't question. At that time, you didn't question your doctor. And then after that, I went on Avonex. I don't know why he switched me to Copaxone. And then this is the last drug I've been on, is the Orcavis. And now I'm wondering, is it too strong? Should I really be on that? Do you know what I mean? Because I have noticed that this was last year. I started getting thrash on my tongue. I'm like, what in the world's going on? You know what I'm saying? Like I was questioning myself, like, did I make the right decision? I don't have any side effects from the infusion, but I have to factor a lot of things in, if that makes any sense. But so far, I don't have any new lesions. I guess I'll just deal with the thrash or whatever. I try to eat healthy and I try to keep myself healthy. That's all I can do from my end.
Yeah, that's such a critical role as well in the things that lifestyle choices that can help. That's great to know.
Yeah.
That's what benefits.
Yes. And that's about it.